Okay, just show your history. What have you got in the history?
So the patient's name is JA, 60 years old female and a Filipina with a birth date of November 11, 1961. She was born in Cebu City and is currently residing in Talisay City. JA is a Catholic and a retired teacher, and she is already a widow. Next. So the patient's main complaint which prompted her to seek medical help and which is most concerned about is vomiting blood or hematemesis in medical terms. So the patient's history of present illness are the following. 6 months prior to consultation, the patient was admitted due to having epigastric pain, non-ulcer dyspepsia, and she was given antacids, improved, and was sent home. Ay, sorry, Doc, wala na ako na-delete. Sent home. So 3 days prior to consultation, the patient felt on and off cramping pain with a pain score of 4 out of 10 on the epigastric area, which is not associated with meals. And the said pain does not radiate to the back and has been causing her discomfort for the past few days. And the pain usually lasts for 2 to 3 minutes. 2 days prior to consultation, the patient noticed a change in the color of her feces as well as the presence of blood. Her friends commented on how pale she was and how lightheaded she felt. 1 day prior to consultation, um, there is still a persistent pain score of 4 out of 10. Then the for the patient's past medical history, the patient took antacid 6 months ago. No history of hypertension, diabetes, and asthma. No previous surgeries, therapeutic maintenance, and also no history of psychiatric consults. So the first menstrual period of the patient starts at the age of 14. No known allergies to food and medications. The patient had chickenpox when she was a child and had got the COVID-19 vaccination last May of 2021.
So for the family history, the patient have no known heredofamilial diseases such as asthma, diabetes, and hypertension. No immediate family history of neoplasms other than her husband who died of colon cancer also. The patient's parents died of natural causes. The patient have 3 children that are all generally healthy. Next slide, please. So for the personal or social history, our patient is a widowed retired teacher who is active and exercises regularly. She still participates in marathons and her diet is mainly of fish and vegetables. She's not fond of taking herbal medicines and she was a frequent smoker in her younger years, but stopped around 20 years ago. She drinks occasionally but had not consumed any alcoholic beverage for the past year, and she has no history of illicit drug use. Next slide, please. So for the review of systems, and generally the patient felt lightheadedness and experienced fatigue. The patient also thinks that she lost weight, and she also noticed that her abdomen was getting protuberant and the patient had experienced no fever. For the skin, patient's friends noticed that she was becoming pale, but other than that, there were no significant changes that was noticed. For the HEANT or the head, eyes, ears, neck, and throat, the patient did not experience any headache. And the patient experienced lightheadedness, and there are no other problems in the eyes, ears, nose, and then the throat. For the neck, there were no swollen glands, lumps, pain, or stiffness. For the breast, no lumps were uh, no lumps were noticed, no pain, discharge, or discomfort. For the respiratory, the patient did not have cough or sputum production. For the cardiovascular, The patient did not experience any chest pain or any heart trouble. For the
When you
gastrointestinal,
present your PE, if it's unremarkable, you don't have to present. Just go on with the pertinent. That way you
okay,
can focus more on the physical exam that will actually matter in your case. So go
okay, Doc.
to,
Thank you, Doc.
you can mention the other are unremarkable, but patient's general conditions, lightheaded, fatigue, then gastrointestinal, vomiting, so you focus more on your gastrointestinal because that's where your findings are.
Okay, thank you, Doc. So for the gastrointestinal, the patient experienced vomiting with blood prior to consult, and she also experienced crampy on and off epigastric pain for 3 days, each lasting for 2 to 3 minutes. The patient also experienced getting full easily, and her appetite decreased. The patient also experienced having tarry formed and sometimes mucoid stools. There is no change in bowel movement and no jaundice. Next slide, please. So for other systems, the examination was unremarkable. Next slide, please.
If you don't have the data on the height and weight, then don't add that.
Okay ra, Doc, if di na lang may ask karon, di na lang na siya i-add.
I-add na lang, butangin na lang siya let's say 5'4" on niya kuan. Kasi 5'4" and then weight of 50 kilos.
Thank you, Doc. So for the physical examination, for the general survey, the height of the patient is 5'4", and then the weight is 50 kilograms. And then the patient is conscious, coherent, cooperative, ambulatory, and oriented to time and place. For the vital signs, the patient's blood pressure is 100/60 millimeter mercury, heart rate of...
Slides because you're going to be presenting this anyway. Just show lang on slides. So put in the height and the weight. Then
Ay,
next
edit na lang tayo. Okay, Doc. Pa-edit na lang ko, guys.
Next slide na lang. Next slide.
Next slide na lang. Okay, Doc. So, next slide, please. So, seeing that her vitals out.
So I thought you already have the physical exam.
No?
Na, di ba, nag-present naman mo sa physical exam. So this slide is redundant.
RO.
Hindi naman mo physical examination before sa yung review of systems.
I think, Doc, wala ra ma-change ang heading, ani. This is still under the review of systems.
For your review of systems, if there are none, there's nothing significant, then just put there. Ayaw na mo pag-focus sa, pagbalik-balik ba? Because you're focusing on something that will not change the course of your case.
Sige, this is noted, Doc. We'll just change
Thank
the
you, Doc.
slides.
Sige, next slide. Also the same. Balik na po mo explain sa inyong abdomen when you already had your abdominal palpation before. So ayan na, remove na siya. Sige, what's your impression? Then how were you able to arrive at gastrointestinal tumor?
So for the basis of our primary working impression, Doc, we took into consideration the patient's risk factors, specifically the patient's age. We also took into consideration the things that we noted during the history taking, specifically the vomiting of blood with accompanied epigastric pain and body malaise. And for the physical examination of the abdomen, upon inspection, we were able to note a protuberant mass at the epigastric area, and this mass was noted to be soft and palpable. And for under your GIST, it is considered to be one of your soft tissue sarcoma, and your hematemesis or vomiting of blood is usually associated with your upper GI bleeding, which could be associated with the malignancy of this form of sarcoma. However, for your GIST, it is important to know that there's no specific pathognomonic signs, which is why we have to incorporate our laboratory testing and imaging studies to arrive with a final diagnosis. And we will be presenting the results of our...
Remember, at this stage in your patient's assessment, you only have the history and the PE.
Yes, Doc. That's why
So, the
we
other
will
labs,
still have to elaborate.
don't put the other labs into consideration yet.
Okay, Doc. Yes,
That
Doc.
means you don't have the other labs. So what made you arrive at the primary working impression that so specific, such as GIST?
Doc, would it be possible if we just say gastric neoplasia instead, and then we go with our GIST after na lang our laboratories?
You can even specify. Pwede mo naman yung specify. You can just put gastric cancer.
Okay, Doc. Noted, Doc.
Anything. Okay. At this point, remember,
Yes,
you don't
Doc.
know if it's a GIST yet.
Yes, Doc. Sige. We will change this to our gastric neoplasia na lang.
Yeah, said neoplasia. Neoplasia is a histologic na diagnosis.
Okay, so gastric cancer na lang, Doc.
Or you
Thank
can
you,
go
Doc.
to gastric cancer or kanang you can base it on your history, on your PE, gastric cancer. Then you can just focus more on, because this one, it will show na your bias. Your bias because
Yes,
you
Doc.
already have the histopath. But
Sige, Doc.
imagine if you don't have the histopath yet, how are you going to prove that your primary working impression is a GIST based on the history and the PE?
Yes, Doc.
No, you can do that if you really want to put GIST as a primary working impression. Just be sure na you are able to defend your primary working impression based on your history and PE alone, without the use of any laboratories. So it's up to you. You can use either a different primary working impression that is more generalized, or you can stick with your GIST. Just make sure na you're able to defend that based on history and PE without using your labs.
Sige, Doc. This is
Okay,
noted. We'll just update our slides. Thank you so much, Doc.
Next ka no.
So for our laboratory tests, I think the first slide to introduce this got deleted, so we're just gonna edit it again. So for our lab tests, although there are no laboratory tests, again. No, Doc?
Explain you don't have to explain the report now because you will be reporting it on the proper kuan. So this evening is just a review of your slide, because I
Okay,
won't
Doc.
be giving inputs anyway on regards to how you handled your case, because it will be biased.
Okay, Doc.
No, it's up to you how you handle your case. I'm just going to add, if you have anything that is pareha to your working impression, how you should approach that, kana lang. We will
Okay,
not
Doc.
tackle on the specifics this evening.
Okay, Doc. Okay, so
Diyan ang urine test.
we may also order a urine test to detect for elevated 5-hydroxyindole acetic acid, which may be
Why?
indicative for this may be indicative for any presence of carcinoid tumor, Doc.
Like, why would you
Uh,
request that?
Routinely, Doc, we would order for usually, Doc, and routine workup, we would order urine test, Doc, for like general workup for patients who present with any non-specific abdominal symptoms. So if there will be a chance that there will be an elevation of the hydroxyindole acetic acid, Doc.
Remember, you don't request that to all patients. So
Okay,
what
Doc.
what gave you the impression that you should request that in your patient? Kaya naman na siya. If you can prove that you need to request that on your patient, then go ahead, put that. But my question is, why will you request that?
Okay, Doc. Say, Doc. I'll make that as a learning issue, Doc. I would also like to inquire, Doc, if there was any other laboratory tests, Doc, that we forgot to ask, if it's
Wala.
okay. Okay,
Katora.
Doc. Sige, Doc. Thank you, Doc.
So for the salient features of this case, firstly,
Yes,
the
go, next slide. You don't have to present.
okay, doc, thank you.
Okay, pare na. Abdominal mass. Smooth, regular border movable. Okay, because you're putting there, example, intestinal leiomyosarcoma. Your GIST is also a sarcoma. So that means any features that will be present in your leiomyosarcoma should be the same as GIST. No, it should still present as early satiety. Ayaw ninyo don't selectively look for don't selectively look for positive or negative your pertinence. In fact, if you cannot rule out, then that's okay. You can put there all positive. Now, for example, your gastric malignancy can present with abdominal mass. It can present with epigastric pain. It can present the same way as GIST. So that means why do you have to rule it out? So what you need is something that is more likely for this patient. So is it more likely to have GIST or gastric cancer for this patient based on the risk factors? Okay, is it more likely to have peptic ulcer disease? So that's how you should explain your differential. Sige, next slide ko no. Sige, next. Okay. Next. Sige, next. For your ECG, no, since you're students, how are you supposed to interpret that? Is that just normal sinus rhythm? Okay, it will make a good habit if you can interpret your ECG.
Hello, Doc. Good evening. Sabi kami, Doc, like heart rate, heart rhythm, P wave, PQRS, kana, Doc.
Yes, you can interpret that.
Okay, Doc. Noted,
Diba?
Doc.
Kay, kung man po na siya, kung sabihin yung first yung buhaton, so you can have rate, rhythm, kana.
Doc. Thank you, Doc.
You can put there, you can interpret the ECG if you want. The same way with the X-ray. Okay, next. So for this patient, no, you have to do this in sequential order. Okay. So sequential order. For example, when your patient arrived, diba, nag-vomiting pa siya. Okay, so before you do your diagnostic modalities, you have to insert your initial management for this patient. Nag-vomit pa siya. If you do your diagnostic modalities now, then that means what? Your patient, no? How do you prepare your patient for the endoscopic ultrasound? Are you going to do endoscopic ultrasound first? Because that's not endoscopic ultrasound, what you're showing. So for this patient, before you proceed with your diagnostic modalities, you explain first what you did in the ER. Okay, the patient is tachycardic. Okay, so how are you going to prepare the patient for diagnostic modalities? And what's the sequence? What are you going to do first? Are you going to do X-ray or endoscopy or ultrasound? So you have to be specific because this is a case presentation. You have to specify the correct order in how this patient is managed. So for kaninga patient, take note the physical examination findings. Take note the presentation of the patient. The patient came in for upper GI bleeding. Remember that the patient is currently having hematemesis. So are you going to send the patient right away to do an endoscopy? No, are you going to schedule an endoscopy? Let's say endoscopy is scheduled tomorrow. Does that mean you're not going to do anything to the patient? So indicate your management of the ER. Then how are you going to prepare your patient for your diagnostic workup? Okay, next. That's not the endoscopic ultrasound. That's the endoscopy. Sige, next.
Yes, doc.
So that's the endoscopic ultrasound. Okay, so if you can explain what the endoscopic ultrasound, I think I sent you the slides. There is already the interpretation. So you can put the interpretation there. Okay, next. Next. So explain the one. Explain the rationale for what makes it. What's the advantage of having a JEC that's CD34 and S100 negative versus positive? For this one, if possible, make the picture larger para mas dali ma-visualize. Sige, next. Okay, next. No, ayun na, you don't have to put in the basis because you already have the laboratories at this point. So next. Okay, next. Okay, next. Okay, next. So for this patient, remember your management should be tailored towards this particular patient. So not the management of GIST in general. So kani siya, this particular patient. So that's the flow of your management. Sige, next. So go back one slide. Indicate the dose, indicate how much do you give per day, indicate how long are you supposed to give for neoadjuvant. Okay, then read on your second and third lines, that one. Then what happens if, can I go back next slide? Okay, so why a CT scan? What's that PET scan? Why a PET scan? What's the advantage of doing a PET scan? You read on that. The next. Okay, then when are you supposed to get the CT scan? After your neoadjuvant chemotherapy. Okay, so you also read in case you are asked. Okay, what if the GIS did not respond to the imatinib? What's your options? Okay, and when are you, for this patient like this one, what's your next plan? So say after the CT scan, next. Okay, next. So kakaniya, you have to indicate when is the proper time for surgical resection for this patient.
Yes, doc.
And then that one, that's outdated. Tumors 2 to 5 cm in size. You look at the new NCCN. When is laparoscopic indicated? Because there's a new criteria now that's changed just very recently. Sige, next.
Okay, doc.
Okay, next. Okay. So when you give like a management, no, post-operative follow-up, you have to be very specific. So don't put there, consider continue adjuvant imatinib. Okay? You already have the histopath findings. So based on that histopath findings, what is the recommendation based on that histopath findings? Okay, then imaging. What imaging do you need for this patient? What specific imaging? Sige, next. Oh, pulmonary toilet. Are you going to give pulmonary toilet for this patient? What pulmonary toilet are you talking about? Since you're presenting a case, you specify. Do not say antibiotics. You mention what antibiotic are you going to give? Specific name. Monitoring, you mention how are you going to monitor? Don't just put there monitoring. And are you really going to do a pulmonary toilet for this patient? Sige, next. Again, surveillance, indicate how are you going to do your surveillance. Okay, what is the interval? What specific surveillance do you need? Sige, next. Next. So, because discussion na niya after. The reason why you want to focus more on the person, you have to discuss on your GIST. So that way, your presentation, your case presentation, should be focused on the patient. So what's happening to the patient? How you manage this specific patient? Okay, so how was this specific patient managed? Why do neoadjuvant? Why not just remove everything all at once? Okay, then how are you going to follow up? Because after your discussion or after your case presentation, you have to discuss GIST anyway. Okay, so when you discuss your GIST, you don't have to be very detailed. You just have to explain everything that you did on your case. For example, why imatinib? So what's the mechanism behind imatinib? Why do CD117? Okay, so what is GIST? So that's the core topics that you need to discuss during your discussion. Sige, do you have anything that you would like to clarify? You know what?
Dok, mangutana lang po, Dok, kanang sa katong kontok, no, wala man to genotyping, Dok,
Sasa.
sa katong sa patient, Dok. Baka nalimtan na mo pangutana, wala man to, Dok, na.
No, we don't do genotyping here, man. So there's no genotyping for this case.
Okay, thank you, Doc.
But we do staining. So you have to specify what's the advantage of staining.
Doc, mag-ask round kami kung unsa ang blood type sa patient, Doc.
Talabot lang, A positive.
And then, Doc, naka-mention ka last meeting na to, Doc, nga ay, i-manage, di ba, ang patient sa ER kaya unstable siya. Transfusion siya o blood dayon, Doc? Or waton pang CBC to check if pila yung hemoglobin o hematocrit before siya transfusion?
No, in the proper context, no, dili man na trauma yung patient. So you can give fluids before you do your blood. So don't give the CBC. Kana yung CBC, your CBC and your hematocrit is not the basis on whether you should transfuse your patients or not. Because CBC is a chronic change. Dili man na mo change tayo yung imuhang hematocrit, yung imuhang CBC or yung mga BC levels if the patient is acutely bleeding. So you have to put in your vital signs, okay, your tachycardia. If the patient is tachycardic, if you remember your class of shock, no, if tachycardic ang patient, what class of shock is that? And what is the approximate blood that you should transfuse? What is the approximate blood loss for those patients? So dili ka mo wait sa imong CBC.
Thank you, Doc.
Any clarification? I will not be adding to your slide because it might be unfair for the other groups. I'm just here to check on your presentation, and it's up to you really to help and how to interpret and how to present. So putangi lang, just it's important manggod na you have to know the immediate management of these kinds of patient. Okay, you don't just order your labs and forget about the patient. If the patient arrives because of upper GI bleeding, then you really have to manage that patient first before you think of doing your workup. Okay, and remember upper GI bleed, and if you do your endoscopy on these kinds of patient, you will not see anything. You will only see blood. So you have to indicate what is how do you prepare a patient with upper GI bleed for endoscopy. Sige, any other questions? Okay, so you
Naay
can,
siblings si naay siblings doc atong patient.
wala lang. Make it simple. There's no siblings.
Thank you, doc.
Okay, so this is actually an actual case, but the problem with the actual case is the actual case is very complicated. So I'm just removing some of the variables to simplify your case. So for this patient, no, when you make your initial impression, just remember, do not use the data that you don't have yet. If you don't have the laboratories yet, don't use the laboratories to make your differentials. Okay, so if you only have your history and PE, then just put there the differentials and the impression that you can make based on the history and PE alone. Then after your workup, you can put again your differentials. If you change your differentials or if you change your initial impression after the workup, then that's okay. That's why they called it, it's called initial impression. Pwede man mo i-change. You're thinking of gastric cancer for now, but after doing your workup, turns out it's GIST. Okay, or maybe you're thinking of PPUD, then after your workup, it's GIST. So that's acceptable. Okay, any other questions?
Doc, I'd just like to clarify for the flow of the slides, Doc. Should it be that the primary impression goes first after the differential diagnosis, and then we present the lab tests that we would request? Is that the
Normally,
correct order, Doc?
normally you present your primary impression first. Okay, because based on your history and PE, what is the most likely problem of this patient? That's your primary impression. Then you present your differentials because your thinking is, if it's not my primary impression, what else could it be? So that's your differentials. And then your differentials will dictate what laboratories you need. For example, if you have a differential that is GIST or gastric cancer, how are you going to differentiate GIST and gastric cancer? Okay, can you
Okay, Doc.
differentiate it by CT scan? If you can differentiate it by CT scan, then of course you will get a CT scan for your laboratory. Okay, if you need endoscopy and biopsy to differentiate your differentials, then that's what you will request.
Okay, Doc. Thank you so much, Doc, for the clarification.
So specify why that specific or why that particular biopsy. Why get an endoscopic ultrasound guided FNAB? And why get a biopsy for this patient? Okay, so you have to explain.
Thank you, Doc.
Doc, ako lang i-clarify katong sa review of systems sa PE. Asa mo i-remove ato do ang sa PE kay redundant na siya?
You can keep the PE. So ang PE, no, you have the PE there, and then the review of systems, diba? So what is the difference between the PE and the review of systems for your case? So what's your thinking? What do you mean by your review of systems, man? Okay, if you do your PE and then you already put everything in your PE, then that means you don't have to do your review of systems because na naman diha tanan review of systems in yung PE. Why are you going to do the eyes, ears, nose, throat if you already put head and neck on your PE? So the review of system is, the concept of the review of system is in surgery, especially in surgery, no? When you have a patient like this that is unstable and you want to know the cause or the impression, you do your physical exam, but your physical exam is focused. So in patients with melena or patients with upper GI bleeding, of course, you want to do a focused abdominal exam for this patient. You will not do head and neck. Why are you going to do assessment of the head and neck for this patient? Diba? When the patient's problem is your upper GI bleeding. So that's why that's your PE. And if the patient is stable enough that you have time to do the review of systems, then the review of systems will comprise the entirety of your physical exam from head to foot. So that is when you do your head and neck exam, you examine for jaundice, you examine for everything else. So that's the concept of the review of system. But if you already put everything on your PE, like let's say you did the PE thoroughly at the ER, despite the patient being unstable, so why do you have to repeat your review of systems? So that's the one. That's the redundancy there. So it's either you put a focused abdominal exam for this patient, and then after you did your primary impression and everything, or after your PE, you can put in your review of systems that will review the other systems that is not included in the focused abdominal exam. So that's up to you.
Thank you, Doc.
Okay, katong redundancy is katong after ba? After, why do you have to repeat the review of systems and do pertinent? Diba? You already mentioned the pertinent. So stop repeating your PE. Just indicate your PE once and that's it. You have to be brief and be accurate in your clinical presentation because as we mentioned, you have a lot to cover and you're already spending 50 slides and you're not yet in your review. You're not yet in your discussion. So that means after your discussion, you will reach 100 slides and you will take 3 hours. Okay, so just present the case as is, as simple and as accurate as you can present it. And then focus more on how you are supposed to handle the patient and then discuss your GIST and the concepts of your treatment. So if you're treating the patient with neoadjuvant chemotherapy with imatinib, then that's part of your discussion. What's the advantage of treating the patient with one? So it's kuan ba? Your case presentation man good and the discussion, it's basically just you trying to defend what you did to the patient. No, so in the concept of surgery, when we present cases and we do a discussion on that case, we are discussing the concepts behind our treatment. Like for this patient, what if you did not do imatinib? What if you went outright surgery? So you're not going to discuss neoadjuvant imatinib. What you are going to discuss is what are the advantages or the concepts behind outright surgery in GIST. Why do you need to do surgery in GIST? Diba? So in this patient, you requested for CD117, you requested for your S100 staining, then you defend. CD117 staining is a staining used to do this. It detects blank, it increases the prognosis of possible metastasis to where. Diba? It can differentiate a GIST from being low grade, being high grade, those things. So that's how you are supposed to handle your discussion. So do not discuss GIST, all of the GIST pod like you are going to discuss the entire NCCN. What you will be discussing in your discussion is mainly what you did to the patient. Kana lang. Don't discuss everything. Don't start with basin mag-start mo sa pathophysiology of the cell na pod. So ayaw na. There's no need. Anything else you'd like to clarify?
Ay, Doc, I have a question lang, Doc, ba, regarding sa kay the patient mo, Doc, kitagaan sa initial workup na treatment. So, ni gamay ihang mass, but we don't know man, Doc, na what ka na, sa to na treatment or drug gi-use, Doc, ba? So, can we assume, Doc, na kato na lang imatinib ang gi-use, Doc, or na-adjure specific drug, Doc, na wala ni nakakuan sa history, Doc?
Wala ninyo na-ask. So this patient received initial imatinib.
Okay, sige, thank you, Doc.
Wala niya na-recall ang dose. That's why you have to indicate what's the dose of your imatinib and what's the duration of your imatinib. And then when are you going to repeat the workup? Okay, how are you going to, kay kanina patient ha, you still lack katong, I give you the CT scan, the x-ray of the chest. What's the ideal? Is it really just the x-ray of the chest? Or is it something else? So how are you going to manage with the patient before surgery? What are you supposed to request before surgery? Okay, when are you going to recommend the surgery and what are you supposed to do after the surgery? Sige, anything else? Something that you'd like to clarify? Rara? Were you able to get your case? Are you ready for the presentation?
We will be editing some of our slides na lang, Doc, for the presentation.
Okay, so in case, remember, kani siya nga patient, no? Just treat this as your case. That means you're the one managing this patient. If you feel the need to modify, let's say what is the wala man ninyo na ask in sequence ang iyang test. So it's up to you. What is the first test that you should do? What should you do next? Okay, are you going to do the CT scan first? Are you going to do the endoscopy first? So those kinds of things that you need to work up on. It might not matter, but you might be asked, no, why you requested this? Why was this done? What's the advantage of the PET scan? Why do you have to do a PET scan and a CT scan? Do you really need to do the PET scan and a CT scan? Okay, and interpret your PET scan and the CT scan. Any imaging that you flash on screen, you have to be able to interpret. Sige, so Shom, no more questions?
Doc, pwede mag-ask if busy ka tomorrow.
Pwede naman. You
Pero
just,
na mag-meet, Doc.
you can tell that time. You can message
Ask
the time.
me. Sige po. Thank you.
So you have time to edit the slides.
Yes, Doc.
Okay,
Thank
sige.
you, Doc.
If there are no more questions, if you need to have another meeting tomorrow, we can meet tomorrow.
Thank you so
Thank you,
much,
Doc.
Doc.
Thank you, kay
Doc.
Thank you,
Doc.
kay Doc.
Hi, guys.
Ano?
Stay lang sa mo. Okay, magsabot sa taon-saon. Hello, hello. Hello.
Kung sa inyong evaluation
Hi.
sa to ang
We did
Like,
kita prepared. Wala pa gito. Mura to sa jema-jema.
A house tour
Listen,
ka
guys.
Uy, dili jud confident.
Dili pa gito mo, promise. Sige lang. Atong sabutan kung unsay flow jud sa tong slides, no? Kasi I think mo gyud to siya ang one of the things nga need na to i-clear. Sorry sa jud kaayo. Wala bitaw jud ako natagad ang slides pod kay na daming ganap. Anyways, so complete na ba ta? Or nanay nang wala? So ang giingon ni Doc no kay ang katong PE ug ang review of systems kay redundant na. So unsaon na to ang physical exam?
Ingon si Doc, ganihate di ba murag iuna ang PE?
O
And then-
una ang PE but then
An-
unsaon ni
Ang ROS.
ang atong PE kay i-focus lang nato sa abdomen or and then mag-ROS na lang to sa other systems.
Mao yung ingon ganiha.
No.
So focus sa abdominal ang sa PE. Ang sa ROS kay head to toe.
Okay, except abdomen.
Hmm.
Sige go. So ana na lang. So physical examination, mo na lang siya more thorough abdominal physical